Welcome. My name's Julia Briscoe. I am the Clinical Fellow for Personalised Care. I'm working with the training hubs and with Health Education England. And my role has been, I started last September. My role is around influencing and embedding and supporting personalised care roles across North East London. So I've met with a lot of really interesting people and I've come across some wonderful work. Last week, we did a webinar on personalised care roles, the three main roles. So those were care coordinators, social prescribing link workers, and health and wellbeing coaches. And this week we're going to do this webinar about how we grow the expertise and how we make sure that our personalised care practitioners are now core members of our MDT. So and just quickly to say that this is being recorded, so it's going to be put on the Training Hub website as a resource, as a repository. And I know from last week's session someone was going to do a watch party. So it's supposed to help induction. So the purpose of today is to support induction of new practitioners, but also it's a reinduction, because don't forget, really we are still slightly coming out of lockdown. So for 2 years really those roles have been in a slightly compromised or different position, and slowly we're shifting into a new way of working. So it feels like this is really good timing to also reinduct or re-energize the whole agenda. So I've introduced myself. We've got a panel of 3 really strong speakers, and I'm going to try to stop speaking as soon as possible because we want to hear from them. My next slide, please, Johanna. That's great. Thank you. So just a quick recap. Personalised care is based on the comprehensive care model. It's been supported through Rs funding, which is the additional roles reimbursement scheme. People have in the past been calling them Rs roles, but I've stepped away from that and calling them personalisation roles. I mean, people, or even by their name, health and wellbeing coach or social prescribing link worker and so forth. The comprehensive care model is based on 6 elements: shared decision making, personalised care and support planning, enabling choice and including legal rights to choice, supported self-management, social prescribing, community-based support, and personalised healthcare budgets. And what's happening is that this is slowly but surely rolling out. There is a whole plethora. We could do an entire series of webinars on this. So for the purposes of today, we're going to look purely at how to make these roles thrive and how to sort of actually help retain our staff as well as grow their skills, how to create a collegiate sense amongst all of you, and also how to embed these roles within current MDTs working and becoming a core part of daily work. So personalised care, just as a strapline, is what matters to you as opposed to what's the matter with you. So there's a real culture shift in the way we are speaking to people and actually trying to create some agency and authority and autonomy over their own health and well-being. So if I could have my third slide, Jana. Thank you for your help. And just a quick quote from the World Health Organization. This is actually sitting in the NHS England personalised care paper, and it says, so health systems are often unaccountable to the populations they serve. So quite often we're just getting on with it. We're not necessarily accountable to those populations, and therefore have limited incentive to provide the responsive care that matches the needs of their users. People are often unable to make appropriate decisions about their own health and healthcare, and they're also unable to exercise control over decisions about their health and that of their communities. And this is what I think personalised care in particular helps to support and address. So what do personalised care roles need to thrive? I'd like to go straight to the first speaker, which I've asked Sharon and Cyber. They're going to be presenting, and they're going to talk about, well, I'll let them tell you, but it's going to be about supervision in Waltham Forest. Thank you.
Thank you very much. And just to say a little bit in terms of context, so I'm the senior social prescriber at Waltham Forest. I used to work in Tower Hamlets, came over to Waltham Forest 2016 and set the service up. And in Waltham Forest, there's a telephone service. Before COVID, it was, it wasn't face-to-face. So our colleagues have talked to thousands of people, but not seen hardly anyone. So that's the service we have. And then in 2000, I always call it April Fool's Day, 1st of April 2020 is when we had the new 9 social prescribers in primary care that got recruited. And poor things, they were recruited to an empty surgery with the pandemic just starting. So I really felt for them. So in terms of a context, it's interesting that Julie said in that introduction about the personalised care roles and how they can thrive. And this is not, in my experience, the lack of people having the skills, the ability, and the energy to want to thrive. Thriving is also very much about where they are. And when they are in a lot of primary care settings, it's not conducive to thriving. And I will say that. I say it publicly. I'm not frightened to say it. And in order for us to look at thriving, what I'm going to talk about, obviously, me and my colleague Saiba, is the supervision. But we can do all of these things. And Saiba is one of our wonderful social prescribers who actually went on our NEL leadership course. All of these things can be put into place and people take it up. And then if they go into a setting that is not rewarding and supporting and developing them, it's a big problem. So I always say that to everybody. I had a meeting with someone from PCAN. I don't know if you've heard of PCAN. And I forget what the C is, Primary Care Anchors Network, yesterday. And her role is to look at developing the personalised care roles. And I said, and what can you do about the environment and the culture, inverted commas, that they're in? And unless you can do some of that changing, all well and good us having all these other models until we do that. So I'm just putting that there, just as that couches the context of where we are coming from. So in Waltham Forest, I cottoned on very quickly. I don't work in primary care, never have. I work in public health and the local authority, and I'm quite happy to stay there. So in terms of primary care, I got a lot of the feel of it because I developed a relationship with the 42 GP practices in our borough before the primary care social prescribers came on board. And that's good because some are very well-meaning and very visionary and others aren't. But we had a good development of that relationship, and we have 7 primary care networks. And I saw very quickly, due to the pandemic, but also time and capacity, as we all know, the social prescribers were not getting any supervision. So I had to put my thinking cap on. We could say all this and we can say they should and all that. The GPs and the clinical director said, yes, we want to do it, but it really wasn't happening. So I went to our Waltham Forest training hub. And if you go to the slide that has the case study, so in terms of the approach, we wanted to look at how we could support the social prescribers in their roles. And so the challenge was for me to try and get some supervision from them during the pandemic. And so what we did is we talked to various different people, and one of the people were Bromley by Bow Centre. Most people know of them, and they had a number of people who are, I think, psychotherapy trained, people who understood social prescribing and who were doing external supervision. So I put in a bid to the training hub. They came back and said, before I go into that detail, that they wanted group and peer supervision. I said, no, I don't want that. I'm putting in for one-to-one supervision for our 10 social prescribers once a month. So I put that in, contacted Bromley by Bow, got a wonderful woman who was able to do the work, Alice Everard. She's psychotherapy background, and the cost, which I think is very cheap for what they get, is we were told we'd get the money for 12 months initially. It works out at £50 per social prescriber per month, and times by 12 months, and that gave us £6,000. Now I know some people can go on conferences and stuff for £3,000 for one weekend or whatever. £6,000 for 10 social prescribers per month for 12 months is a bargain, and what they get out of it is very, very good, and you'll hear from Saiba in a minute about it. So we got that. I also said, I know you don't want to just give money for nothing, but I will do some evaluation. If you carry on, we use GAD-7. So GAD-7 is looking at sort of mental well-being, 7 questions, very simple for the social prescribers to complete. And we have a little survey that they also complete. And we've analysed that after the first year, where we can see that there's been improvement on the impact. It says dramatic improvement in terms of having the supervision. And so I then made the case to say, could we continue for another year, and they said yes. And so we've got the monthly supervision for our 10 social prescribers at the moment until the end of November this year, which would make it 2 years of brilliant supervision. So if you just go up to the last part of this bit, so as I say, the funding came from our training hub, Waltham Forest Training Hub. The clinical directors are aware of it. They're quite happy that someone's doing some of their work for them. And I'm hoping that they can see the benefit of the social prescribers that have it. So if you go to the last part for me, which is go back to the testimonial. So one of my social prescribers has written something in, and then Cyber will talk about her own personal experience. But this was a little testimonial on my other slides from Zakia. So Joanne, if you can bring that up, that would be great. That's it. Yeah, so Zakia, she's been with us for about 2 years, a social prescriber. She's been, as she said, fortunate to have this non-clinical supervision since November, both on a personal and work basis. She's found it very helpful, especially when she's supporting patients and their difficult circumstances that might trigger things personally. It's monthly, as I said, and gives them an opportunity to debrief. And she gave me some examples in her own personal life where she was able to debrief and just get a bit of support from Alice. The external supervision had supported her in many circumstances, as she said, and also helped her to navigate some difficult situations where she might just want to talk through, just sort of brainstorm about situations regarding a patient, and she's able to do that in the supervision. If you carry on, next page, the last page. So there we go. She said it's benefited her to voice and find solutions in difficult situations. But she works with 3 practices in her PCN in Leighton, so she's able to discuss various different things. And lastly, on a personal level, the external supervision has been extremely useful, where she's had to juggle a lot of things from at home, but the supervision has been allowed her to voice her concerns and create a list of priorities for her to balance work and home life. And so she said she's benefited immensely. She's grateful that we were able to put in that bid and that we were able to continue this supervision. So that's what we've done in Waltham Forest, and it's been acknowledged. The case study is now seen as a good beacon of good practice, and it's now shared by Healthy London Partnership and others as widely as possible. So can I just introduce Cyber, who's one of our social prescribers, who started from the beginning. Cyber, do you want to say who you are and your PCN and how you have found the supervision? Thank you.
Okay, thank you, Sharon. So my name's Cyber Salam, and I work for Walthamstow West PCN. I'm part of a job share, so I work on Mondays and Tuesdays, social prescribing. With the clinical supervision, I'm sure I can speak for the rest of the team when I say it's been so beneficial for us. It's something that we've really needed, and especially because it was external. Having it external meant that there was no fear of any repercussions. We could talk openly, and get the best out of it. There was no politics or anything. We could be open, and it helped us both professionally and personally. So, for example, any challenges that they may be in that primary care setting, for example, with other staff members, line managers, etc., we had that opportunity to talk through that with Alice and kind of figure out a positive way of how to, overcome those challenges. Also, I think there's a big danger of social prescribing becoming medicalised within the primary care setting, and so to stop that, counter that, it really helped to speak to Alice, and just for best practice, basically, it really helped, and it was great to talk about any qualms that we might have and help us with communicating what we wanted, because obviously we know what's needed, but we're the ones that are doing it, so we know what we need to change and things like that. So speaking with somebody else with a fresh set of eyes was great. Me personally, I was offered another job. So I also work for Kieran Support Services, who are a charity that work with South Asian women experiencing domestic abuse, and I do their social media. And then so I came to a point where, what do? I don't want to leave social prescribing, but I'd like to take this job offer too. And then I talked about it with Alice, and then I managed to, after speaking to her, discuss with my CD, my clinical director, about just reducing my hours so that I could do both jobs, and they bounce off each other really well. Also, what was it? Yeah, because I didn't want to miss that opportunity, of doing that as well, because I used to be part of Waltham Forest Women's Network, which Sharon founded, and I used to do a lot of the social media with that. So that was a skill that I didn't want to lose. So then I'm really happy now doing both jobs at the same time. She also helped personally to make sure that it can be quite overwhelming, and you do get quite burnt out sometimes, but she'd make sure that we looked after our own well-being in the same way that we encourage our patients to look after do that self-care and that well-being. We need that as well. And I remember talking to her about, because I like to upcycle furniture in my spare time, which I don't have very much of, but just talking about that with her, and just getting that encouragement and helping me to focus and being conscious of my own self-care. And also personally, and very unfortunately, I lost my father about 6 months ago in the middle of all of this. And then it really helped, speaking to her really helped me to focus on what was important for me, but also how to balance work and also anything that's going on in my personal life. So I think it was, honestly, I can't thank Sharon enough for arranging this clinical supervision that's external, because we were just able to just let it all out. It was very, very difficult, especially at the beginning of the pandemic. As a team, we always support each other. We have a WhatsApp where we have banter, where we can have a whinge and all of that. And I mean, there was tears. I mean, at the beginning of the pandemic, there was a big ask of us. There were patients who were suicidal and all sorts, and everyone just pulled together and tried to help all these patients. It was really difficult, but having that clinical supervision really helped us to make sure that we were okay and for us to excel in our job. Thank you.
Saiba, that's so powerful. And Sharon, thank you both for this fantastic testimony.
Can I just say add one thing on, just a little extra, was that I also meet Alice once a quarter. So and it's obviously what she does with the individuals, social prescribers, is confidential. What she does with me is any themes that are coming out. So one of the big themes is I'm always horrified that our social prescribers don't get any sick pay. So that's something that they've been raising. I try and see if I can take it further. And also just what I've learned is that obviously the clinical directors generally are very supportive of social prescribing, but they have delegated that area of one-to-one with in either a practice manager or a physician associate. These people are not always so supportive. So for me, that is another challenge that I have. But I get that because Alice is picking that up from what people are saying. So without saying, oh, this PCN or whatever, she's saying there is a general issue of who's been delegated to look after them within practice. And that isn't the clinical director. So it's good to get that feedback also from Alice. So I hope that gives a sort of wide picture, Julie, of what we've been doing in Waltham Forest.
It does. I mean, obviously, we could spend ages asking you questions about it, because this is one approach, and we're going to look at two other approaches that are being carried out across NEL. So, but what I'm hearing, first of all, I mean, I'm a nurse by my background, and we're encouraged, we have to be reflective practitioners. And I'm hearing that supervision in particular for you is creating an opportunity to be able to work reflectively and actually consider how this is all balancing up. So it also looks at your well-being and presumably therefore retention. And if we think about the cost of supervision versus the cost of actually onboarding, advertising, waiting 6 months for someone to get up to speed in a new role, actually you're saving money effectively in doing this investment. So thank you both very much. I would love to move straight over to Katie and Augusta next, because they have a slightly different approach based in Newham. Straight over to you. Thank you.
Hi, everyone. So my name is Augusta Adu, and I'm the Senior Social Prescriber for South One Primary Care Network. And I co-chair the Community of Practice with Katie. So I was the first social prescriber in Newham when it was all new then, 2019, to see how the service has grown in Newham and really established for us to have this community of practice. So my previous background, I was a care navigator. Then I moved on to work as a care coordinator in similar roles, supporting patient welfare, advocating, supporting to make sure their care is really well resourced, adequate to help them manage their independence in the community. Then I moved on to work with Ealing CCG to do some project managing work and to support organization to really put patient-centered care and achieve their outcome. All throughout this journey, it has really equipped me and support me to continue with my drive and my passion to support patient care and outcome. And having the privilege and opportunity to co-chair with Katie to support our community of practice members in Newham has really given us a place to connect and meet people with similar background, passion, to be able to pull together resources, work in partnership to meet the voluntary sector, talk about services, how we can really nurture our members to grow and thrive. So being part of this opportunity of having this forum in Newham has really helped a lot of the personalized care members to really grow and come together, know each other, know about each other's role, meet regularly, have a place, have a sense of community and support each other. So I'll pass it on to Katie to continue and we'll tell you more about what we do. Yes, so thank you, Katie. So moving on, being part of this community of practice has really helped us to reach our goals. This means that we have been able to thrive as a community, and the reason being that we are all able to come together and support Newham residents to enable them to achieve positive outcomes. So in terms of educating our members about new services that meet their needs, or if there's a gap in service, we'll be able to pick up. We feel that having this community of practice has really helped people to be knowledgeable about all the informations about services in Newham, support our peers. They have really developed their skills and they gain knowledge about how to meet and resolve difficult encounters. We share outcomes, we share experiences and support our members. Our members in particular has been working hard. Some people work alone in their PCN, feeling that they're the only social prescriber or they're only community connector based on a particular area. But when we come together, they see all the other members and they feel part of a wider team. They feel they are not alone. We are able to contact each other on Teams, chat, support each other. And we are proud that this personalized care force in Newham has been able to come together, and we are a community. We don't work in silos anymore. Though you be based in a particular PCN, you know you have another social prescriber or health and well-being coach or community connector based on other PCN, and you all face similar situations. If there's a difficult patient, you know you can talk to your colleague for support. If there's a service you are not sure whether it's discontinued or not, we can work collaboratively to support each other, learn from each other, pool resources. So it's an opportunity for all of us in Newham to have a sense of belonging, to have a source of support, peer learning, to upskill ourselves gradually. And if there's any training or webinar people are not aware, we inform them, join this webinar or join this training, and it helps. So it's very good what we have, and it's opportunity for people to attend and to promote those who are not aware that we have this community of practice. We will be able to accept them as members and they will be part of the team. Thank you.
Well, Augusta and Katie, thank you. And as always, again, another very strong presentation and a very different approach. Obviously, there are overlaps where it comes to being reflective. And what I like about what Augusta said in particular is that there is sometimes, for some people, a sense of working in a silo or working alone. And actually, that's not the case. So I'm sure if people are watching this who aren't working in Newham, maybe they're in one of the other 7 boroughs of North East London, I'm sure that it would be all right for them to reach out to any of the speakers, Cyber, Sharon, Katie and Shule, who we're going to hear from, in Augusta, of course, because I'm sure you can help to point them in the right direction. There are other communities of practice going on. There are other supervision models. So it's a question of just finding where those are. I'd love to jump on straight to Shule next. I know this is going to come across as a little Newham heavy now, but actually these are approaches. This isn't just about the borough. This is how things are approached. So Shule, thank you.
Yeah, well, which is very much connected to what Augusta and Katie has been talking about in terms of our community of practice. So I'm going to give you a bit more information about the kind of bringing everything together and looking at it as a kind of retention support strategy across Newham. Next slide for me, please, Joanna. Thank you. So when we are talking about retention strategy, we are actually looking at improving our culture in Newham and improving, therefore, our staff well-being and satisfaction. For all the reasons both Sharon, Augusta and Katie mentioned, that we want to make sure that our staff in these roles are actually feeling valued, they have high morale and a positive environment. Like Sharon was saying, if they are not thriving in their practices and PCNs, it is going to be really difficult for us to keep them and develop them and see the benefits. And some of those benefits are around improved service provision and patient experience. So we want continuity of care. We want our staff to actually remain longer and have time to develop their skills and expertise. And we want them to, therefore, achieve better outcomes for our patients, our population. And of course, the benefits also around reducing demand on GP time. We all know, and you have already mentioned this, Julia, recruitment is time consuming, staff training, upskilling, embedding them into our systems and practice and PCNs really takes a long time. So if we actually have a consistent approach around supporting our staff, we feel that we are going to be able to retain them and have all these benefits. Next slide, please, Joanna. So in Newham, we are actually looking at a 5-tier approach, really, because we have been doing different activities. Community of practice is one of them, but we thought, how about bringing everything together and get an agreement across the partnership with our partners, including our federation and including our PCNs and our clinical directors, to actually be able to promote a retention support model for our staff. So we are looking at 5-tier system and a support mechanism, really. So day-to-day support and clinical supervision, we actually think that it is the responsibility of the PCNs and practices, and they should be able to support our staff in providing these activities. But as training hub, as federations, we have agreed that we are going to be able to support them in upskilling themselves to be able to provide clinical supervision and so on. So we are providing training in order for us to be able to develop our staff to be able to effectively provide those services. And now we are looking at actual learning sets for our staff members. And action learning sets is that very reflective space. So 8 to 9 people come together in a supported, safe environment, and they bring their cases and they talked about potential challenges, any issues that are raising, coming up, and then they can get the support from an independent person, again, that is actually being able to support them. At the moment, we have started piloting that with our social prescribing link workers, and the aim through this strategy is to actually sustain that and continue doing that after that, after our initial 6 sessions complete. Then the next level is around the community of practice and peer support sessions. Both Katie and Augusta already talked about our community of practice in terms of our personalized care role. So I'm not going to go into any deeper than that, but we are actually thinking of doing that for every other role that we have across Newham. And then the last tier is the actually acknowledged career development opportunities for our staff. So give them the lead roles in terms of retention support models, give them the kind of mentorship and coaching opportunities. One of the discussions that we have, for example, for our personalized care roles to staff to actually take up on facilitation role for the actual learning sets. So we would provide training for us to be able to do that in Newham. And that actually comes across with our aim to kind of increase our approved learning environments, more people coming to Newham and stay in Newham. That's what we want to encourage, and also supported that through all the different well-being activities that we will have in Newham. Next slide, please, Joanna. So again, some of the activities that will make the kind of strategy, our retention strategy here, and you can see in terms of our well-being champions, in terms of our personalized care, community of practice, our action learning sets, all the elements that I already mentioned in the strategy you can see in this slide. Next slide, please. And lastly, here are our action learning sets that we started piloting for our social prescribers. We have all our social prescribing workers actually attached to one of the 3 action learning sets that we are running at the moment in Newham. And we have used this as a kind of stepping stone to develop our whole retention strategy. And at the moment, the feedback that we got from our action learning sets, which we started in February, has been extremely positive, and it is exactly providing that reflective space for our staff. That's the end of my slide, Julia.
Julie, thank you. So that's 3 very, very strong and very different approaches. I know, as I've mentioned, 2 of them are based in Newham, but actually these are approaches and things are taking place in different boroughs. I know Havering have something, Redbridge have something, and so forth. So if somebody's watching this who's perhaps new to the role or is perhaps even feeling alone in their role, you're not alone. There are things going on. So any one of us would be really happy to signpost you if we can and to help you and support you. So that's one of the most important things I'd like you to take away from watching this. Joanna, I think I've got another slide. Have I? Just to keep me. So when we circulate it, and also just for the purposes of it being recorded, I've put some very simple basic resources here if you want to do some further reading, which I would encourage, sort of what it's all about, how they work, and a little bit more in depth. Obviously, when it comes to supervision and so forth, there are more scholarly articles out there too. I think there's one more slide, Johanna. Thank you. So we've got literally just under 20 minutes. I'd love to open this up for discussion. This slide has just got some questions that I thought might be conversation starters, but in fact, I'd be much more interested to see what you'd like to talk about, what you'd like to bring, and what questions you'd like to ask the panel. Now, the ones that I had in my head were, what are your experience of working within these roles? Do you have any other examples apart from what you've heard about, especially if you're from another borough, for example, about how supervision or a community practice has made a difference to your practice? If you're a GP or if you're a nurse or if you're anybody, in fact, how are you bringing these roles and support needs into the MDT? And most importantly, of course, is how are you evaluating this work? So those are just some sort of thought things. Johanna, I'd be really happy just to take that down and open it up, see if anyone's got anything they'd love to contribute or say or ask. We've got Carol. Oh, welcome. You were here last week too. Carol, lovely to see you back.
Thank you. Yeah, I'm quite new in role as personalisation manager for NEL ICB based in Tower Hamlets. So you probably know Natasha, and I'm working alongside Natasha Sutton. So it was really, really great to hear all your presentations. Thank you. It's really good for me to get an understanding of how other boroughs are working, and seeing how we can maybe incorporate them in Tower Hamlets. We have set up a community of practice. I think we've got our second session or third session tomorrow. So but it was, what I'd like to ask is, how have you got people engaged in community of practice? How, have you got everyone going to it? How do you get the buy-in? How do you increase the numbers? So I'd like to put that out there, if that's okay.
Katie, yeah.
Yes, and also in Newham we have Shirley. Shirley has a nice list of colleagues that she normally sent her emails to, and monthly reminders. So we have pool of data for new members, and we introduce them to Shirley to send updates. So we also are aware of our new members, and when people leave, we are also aware. So we also have a steering group in Newham that, as Katie mentioned, we meet service managers, and people do invite us to talk about social prescribing, health and well-being coach, what is happening in Newham. So it's an opportunity for us to promote the community of practice and encourage people to join.
Thank you both. Carol, is there anything else about your community of practice in Tower Hamlets? Because we've heard a lot from obviously Waltham Forest and Newham. Is there anything that you could share that would be useful for us to know at this early point in your new role?
Well, I managed the community of practice already in Tower Hamlets, so but it was mainly cancer specific, so that was my role before this one, and that included everybody across the borough, and also people affected by cancer as well. So, and this one's slightly different, although some of the elements of that have been brought in. So we are doing spotlights in different services coming in, public health, very similar to what Newham are doing. I think we've got weight management and neurological issues tomorrow going on. So we are doing kind of different, but it's just more to try and get the buy-in and the take-up, really, because I don't know how good your numbers are, Katie and Augusta, but I think we're probably around the 20-25 mark, and I think there's an awful lot more staff than that, and it's trying to, I know people are really busy, I get that, and it's how to try and make it part of what they should be doing as well, and sharing best practice and getting to know each other as you've described, because I think that's really important, especially as a lot of the roles are new within each of the PCNs, and they could be siloed, they are getting a bit lost, and it is trying to bring that community together. So no, I have taken a lot from that, and I hope that's helped a bit about what we're doing in Tower Hamlets. We have got the team chat as well going on, and we do share information that way as well, and some networks are more interactive than others, so it's trying to bring on the ones that are a bit quiet, I think, more so it's quite a good idea to maybe to be targeting the managers.
That's really, really interesting. Thank you. And of course, I always say, the quieter voices are obviously often the deepest thinkers, and they often have a lot to say and contribute. So there's something, I suppose, about how we as a community of practice, or in terms of even supervision or action learning sets, actually encourage that as okay, it's not mandatory, but it's really good for you to participate in that. Maybe it's not useful each time, but there will be some nuggets that you can take out and apply to your own life and your own practice in different ways. Yeah, thank you. Anybody else want to ask or suggest or contribute? Anybody from another borough maybe, or even outside Nell? I don't know. I've seen Assad, our very own Assad, pop up. Assad, is there anything that you've worked in other ICPs? Is there anything going on out there that might be interesting for the purposes of this?
Thanks for putting me on the spot.
Always.
Hi everyone. Hello. First of all, apologies. I was meant to be at the first webinar as well, and I was actually meant to talk, but something happened and I couldn't attend, so I do apologise for that. I'm quite a big ambassador for personalised care services myself. In my previous life, for those of you who don't know me, I'm the program director for the Nell training hubs. So I look after the 5 hubs across Nell, and work very closely with Julia, Shule, So yeah, in my previous life, I have been a PCN manager. And I've actually firsthand worked with the personalised care roles, created new service models for them, and always try to think outside the box. Try to think being creative and how to best kind of utilize these roles. I mean, there's something which I'll never forget. This is when PCNs weren't actually they were being spoken about, and they were going to exist, eventually exist. I remember a meeting where we were talking about personalised care roles, and one of the GPs kind of got up and said, "Oh, why are we talking about fluffy roles?" That thing's just stuck in my mind ever since, and I wanted to say something, but I kind of stopped myself. I mean, I think they can make such a massive, huge difference to people's lives. Medication isn't always the answer. Personalised care roles can really make that difference. I don't really have a lot to share at this point in time, Julia. But I mean, if there's any support, any help that I can provide from my end, being so passionate about personalized care, and I know really works. It might not give you tangible outcomes straight away, but it's definitely part of the long-term plan. So if there's any support and help I can give you as the position that I hold in NEL, I'll be more than happy to have conversations and do whatever's required. So
Thank you, Asad, and apologies. You knew that was going to happen, though, didn't you? It's me.
I know, I expected that from you. But anyway,
So-
nice to meet you all.
We've got 9 minutes left if you want to use them and to ask are there any other questions? I know that the time we've used up nearly all of it, so we could finish, or we could open up the discussion a little further. What would people like to do?
Sorry, me again. I don't want to take over, but I just like to understand, because you did talk about personal health budgets on your list, and I don't know if you're going to cover those separately, or are you planning on doing that, or that's not part of this session, I presume. No.
It's not, but we're so the thing about the long-term plan and personalized care is that we could be doing entire courses in it. So we chose just personalized care in terms of these 3 main roles. I mean, obviously there are other roles. There's OTs and physios and pharmacists and so forth. So I just focused on the 3 main roles of care coordinator, health and wellbeing coach, and the social prescribing link workers. In terms of personalized health budgets, there is a lot of work going on behind the scenes. If you were to speak to my colleague Lauren, she's been really behind the scenes on that. It's only just starting to roll out, but it's going to be a real game changer for some people, and especially for you as link workers. So I don't think that I can speak to it as strongly as it needs to happen, and I know that separate workshops will take place. But what I do know about personal health budgets is that they are coming. If they haven't already arrived in your little pilot areas, there are some pilot areas happening, I think Hackney and City being one, then it's definitely coming. And the other thing that's going to be coming is Community Chest, where there's actually some micro funding available for community groups to actually be delivering activities. So if you haven't heard about that, that's also coming. I think both of those things are really going to help those roles in different ways. And it's the personal health budgets are being led by Breda Spillane, who's an absolute force of nature. And I don't know if you've ever come across her. She's wonderful, but she has such an energy about it. But she can cite all these lovely incidences of where a personal health budget has helped somebody through their social prescriber. So, for example, someone wanted to join a walking group to become more active and to be more fit, but they couldn't afford a pair of trainers and some comfortable trousers. So the personal health budget was able to help with that. There's 1,000 little beautiful examples like that. So what I'd say, Carol, that's the long answer to in summary, watch this space, because that's going to become a really important part of everyday work. So thanks for raising that. Thank you.
Julie, just to say, Community Chest has arrived already. We're in our second round of community, just about to open up applications probably next month for Community Chest. And we're in the middle phase. We weren't the first boroughs. The first boroughs were Barking and Dagenham, and I think Redbridge or even Newham. So there are boroughs who probably may long be in their second stage because they started before us. Tower Hamlets, ourselves, I think, in City and Hackney were the later stages. So Community Chest is there. people should look out for it. And if they don't know about it, I'd find out quite quickly, because monies have started to become available to voluntary sector groups.
Oh, I've muted now. Thank you, Sharon, actually. And you're right. I know it was being piloted. I didn't know you were in a second round already. So that just goes to show the momentum that's taking place around personalised care and enabling community groups to then actually link up with the work that you're doing. So it's really good stuff. Thank you. Any closing thoughts? We've got 5 minutes. I'm happy to close if everybody's happy, but I'd love to hear if there's anybody got any sort of thing that they're thinking or would like to contribute. So don't feel that you need to now forever hold your peace if there's nothing else. We're quite happy. So let's close this, but keep the chat coming. So, contact me, contact Katie, Augusta, everybody, Asad, Shule, Sharon, Saiba, and actually big thanks to those of you who spoke today. This has been so appreciated, and I hope it's been really helpful. It's certainly been really insightful, for me to listen to. So you're not alone. I think that's the take-home message. Contact us. We'd love to support you. And thank you very much for attending today. I wish you all a good rest of the day and rest of the week. Thank you.
Take care all.
Thank you.
Thanks.
Bye.
Bye, Julie.
Thank you.
Bye.
Thank you.
Bye.